The size, morphology, site, and access score predicts critical outcomes of endoscopic mucosal resection in the colon. Introduction. Endoscopic mucosal resection, EMR, is safer, more efficient, and less expensive than surgery, and is now accepted as the standard of care for large, greater than or equal to 20 millimeters, laterally spreading lesions, LSLs, in the colon. Although LSLs conventionally have been evaluated primarily on lesion size alone, procedural difficulty, clinical outcomes, and complications after EMR can vary significantly and independently of LSL size. Scoring systems predicting outcomes, such as the risk of clinically significant post-endoscopic bleeding, CSPEB, score, or the Sydney EMR recurrence tool, are useful, but these scores report on one-dimensional outcomes and are limited by their reliance on prior knowledge of the EMR procedure. In recent years, a scoring system developed by expert consensus focusing on size, morphology, access, and site, the SMSA polyp score, has been proposed as a method of helping to grade polyps in order to define their complexity and associated level of difficulty during resection. Its major benefit is its ability to be applied prior to the EMR procedure with information from the referral letter or procedure report. In this study, the authors aimed to evaluate the ability of SMSA to predict critical outcomes of EMR, specifically technical success, adverse events, and recurrence. Background and study aim. The SMSA, Size, Morphology, Site, Access, polyp scoring system is a method of stratifying the difficulty of polypectomy through assessment of 4 domains. The aim of this study was to evaluate the ability of SMSA to predict critical outcomes of endoscopic mucosal resection, EMR. Methods. The authors retrospectively applied SMSA to a prospectively collected multicenter database of large colonic laterally spreading lesions, LSLs, greater than or equal to 20 millimeters referred for EMR. Standard inject and resect EMR procedures were performed. The primary endpoints were correlation of SMSA level with technical success, adverse events, and endoscopic recurrence. Results. 2,675 lesions in 2,675 patients, 52.6% male, underwent EMR. Failed single-section EMR occurred in 124 LSLs, 4.6%, and was predicted by the SMSA score, p less than 0.001. Intraprocedural and clinically significant post-endoscopic bleeding was significantly less common for SMSA2 LSLs, odds ratio OR 0.36, p less than 0.001, and OR 0.23, p less than 0.01, and SMSA3 LSLs. OR 0.41, p less than 0.001, and OR 0.60, p equals 0.05, compared with SMSA4 lesions. Similarly, endoscopic recurrence at first surveillance was less likely among SMSA2, OR 0.19, p less than 0.001, and SMSA3, OR 0.33, p less than 0.001 lesions compared with SMSA4 lesions. This also extended to second surveillance among SMSA4 LSLs. Conclusion. SMSA is a simple, readily applicable clinical score that identifies a subgroup of patients who are at increased risk of failed EMR, adverse events, and adenoma recurrence at surveillance colonoscopy. This information may be useful for improving informed consent, planning endoscopy lists, and developing quality control measures for practitioners of EMR, with potential implications for EMR benchmarking and training.